Okay, so my name is Dominique Denis-Lalonde. I am an RN in Calgary, that's in Alberta, just in case anybody's from elsewhere. I'm a proud member of the Harm Reduction Nurses Association since its inception, and I have been looking forward to sharing this content with you for quite some time. So I'm really glad you've all tuned in. This webinar is going to present the results of the work that myself and some of my colleagues at the University of Calgary have recently published. I'm just gonna. So I wanted to start out with this quote. Harm reduction is that most unfortunate of beings, a term in search of a meaning. You know, and I felt like this was a really good quote to start with, even though it had been written, 25 years ago. I feel like it still sums up a lot of what I'm seeing and why I decided to do an analysis of this concept of harm reduction. So I have worked in a variety of harm reduction environments, and I saw just a whole lot of different opinions and interpretations and applications of harm reduction. So an example is the idea of harm reduction housing. You know, for some people, harm reduction housing meant that individuals are expected to abstain from drugs and alcohol, but they weren't going to be punished or kicked out of their housing if they are caught using. Whereas for other folks and perhaps other organizations, harm reduction housing meant that people were allowed to use drugs or alcohol in their own homes, thus allowing them to be safely housed while using. So I found some discrepancies like this that led me to want to know, what has harm reduction been historically? Where are we now? What does it mean going forward? And I put a rainbow on this slide because I felt like harm reduction is a bit like the double rainbow. It's like, we all love it, but like, what does it mean? And if you have no idea what I'm talking about, you need to go YouTube double rainbow. And I'll just have to assume that people are laughing at my jokes. Here's our outline for today. Like Mary Lou said, I do definitely want to leave time for Q&A and discussion at the end because I'm really curious to hear your feedback and perspectives on this. What I'm hoping that you'll get out of this webinar is to learn about where harm reduction came from and why, and what some of the key characteristics are based on the published literature. I hope that it'll be a bit of a point of reference for the implementation and planning and evaluation of harm reduction in different practice settings, and that it allows us to better communicate about harm reduction so that when we're advocating to stakeholders or we're educating the next generation of nurses or what have you, that we're a little bit more clear about what we're talking about. And now I realize this webinar, it deviates a little bit from previous webinar content from the Harm Reduction Nurses Association, because it's a little bit more theoretical, philosophical, and less tangible. But I hope that it is valuable nonetheless and that it spurs some good discussion. To me, it's super interesting. I'm a little bit of a dork that way. I find it interesting to dissect what the underpinnings are of the work that we do and that we care about so much. Okay, so the work that I did is called a concept analysis, and there's various frameworks for doing this sort of work. The one I chose is a Rogers method, and it's called an evolutionary approach because you're looking at how something has changed over time. I picked this because it felt right, because I didn't want to come up, the purpose was not to come up with a definition or like the one truth about harm reduction. It was more to just clarify this dynamic and evolving phenomena. And to focus on what is possible as a result of understanding and applying this concept. So as such, I want to note that this isn't like the be-all end-all of harm reduction, and there's even some parts of my analysis that I don't necessarily agree with, but it's what's in the literature. So, what's been published so far. So that being said, yeah, I hope it's still useful, but I want you to know that it's a living document. It's always going to be changing. It's just sort of a snapshot of where we are right now. So just a little bit about data collection. There's more in the paper if you're interested in that sort of thing. I did do a database search to find all of the published works that I was going to look at. And I was unable to find any published work prior to 1995 that used the term harm reduction as is. So that's why 1995 to 2018 was included. And you're probably going, what? How's that possible? But it's true. There's a lot of literature out there that focuses on the benefits of different harm reduction applications. We know about the benefits of needle distribution. We know about the benefits of supervised consumption. So that wasn't necessarily what I was looking at. I was looking more about the concept and what does it mean. So there's a lot less on that. I did have some inclusion and exclusion criteria here. So I did focus on health and social aspects of harm reduction related to the use of illegal drugs. Anything that was about tobacco or sex work or gambling exclusively, I excluded from my analysis. Okay, so first part of the process of analysis here was to identify surrogate terms and relevant uses. So on the left-hand side here, you'll see that there's a lot of different terms that harm reduction is conflated with. This first one, harm minimization, that was actually, it's an Australian thing. So the Australian government, they were early adopters of harm reduction, and their national drug strategy in 1985 included harm minimization, which was kind of new for that time, but they did not define this new term, so it kind of remained vague. The World Health Organization, they actually included harm reduction in 1973, and they said that it was an alternative to drug control. But again, didn't define it, not sure what it means. The kind of real emergence of harm reduction as we talk about it today was in 1990 in Liverpool at the first harm reduction conference. So if you will, actually, this is like the 30th anniversary of harm reduction. Amazing. So there's all these other terms that are being used, and some of you in your work might find that some of these words are being used. Risk reduction, risk minimization, even risk management, and I have some ideas about why different terms are being used. It could be because harm reduction is controversial. It stirs up, some feelings that maybe we don't want to bring into the workplace. But the literature pretty clearly is agreeing that we should all try and use the same terminology, the same language of harm reduction, so that we're not diffusing its meaning. On the right-hand side of the slide here is the huge variety of ways in which harm reduction is used. So it is a philosophy, it's a movement. With clients, we talk about harm reduction strategies, harm reduction goals and measures. You might want to establish a program or a framework of harm reduction in a workplace or a policy. And then harm reduction can also be applied to a wide variety of risk behaviors. So today I am focusing on illegal drug use, but sex work, gambling, all these other things harm reduction can be applied to those as well. So you can see here that there's a lot of different ways in which harm reduction is being talked about, hence why I felt the need to attempt to clarify this broadly used term. So the next step in this evolutionary analysis is looking at the antecedents of the concept. So antecedents can be understood as the things that came before harm reduction, or things that have led to the development of harm reduction as it is today. So on the left-hand side, you have sort of historical things. We know that some of the first examples of harm reduction were opioid replacement therapies happening in the 20s, where physicians were prescribing opioid replacement therapies off-label for opioid dependency for their clients who were dependent on opioids. From there, we are all familiar with the HIV/AIDS crisis, which led to the establishment of needle distribution programs in Europe in the 80s. And these are kind of interesting because, the HIV/AIDS movement and needle distribution programs, those were anarchist practices, right? It was drug users who, upon seeing their community struggling, they began supplying sterile injection supplies to other drug users out of their backpacks without government sanction or funding. They just did it because they knew that it had to be done. And that anarchist practice has now been institutionalized as public health policy and is now funded, right? So the needle distribution programs that we have, I mean, they're still not as widely available as we would all like, but for the most part, it is good public policy to have needle distribution programs. So that's in the past. Going forward on the other side of the slide here, these are kind of emerging concepts that are contributing to how harm reduction is being developed, if you will, today. So I guess the first one here is just that addiction and drug use, we're increasingly recognizing that these are complex, multifaceted issues. You know, they're not moral failings. It's much more complex than we had thought in the past. I think the recognition that the failure on drugs, the prohibition of drugs, the drug war, that failure is causing significant harm and is probably the primary source of harm for people who use drugs. And that's contributing as well to how harm reduction is being interpreted today. And then, of course, stigma. So there's a lot of strong awareness work happening around stigma related to drug use, and that's interwoven into harm reduction work as well. So it's interesting to note to remember that the term harm reduction only emerged, 25, 30 years ago, yet there were many instances of it happening well before then. It just maybe hadn't been fully conceptualized. Okay. So using this approach, I identified 7 key attributes or characteristics, and we're going to discuss each of these in more depth. And in the last 3 years, some of you, who are harm reduction dorks like me, you'll notice that there's a few other authors and organizations that have developed their own principles of harm reduction. So Harm Reduction International, Harm Reduction Coalition, and then there's a few publications as well. And it's interesting because they all have similarities, for sure. They're all quite close, but there's differences in language, specifically in language use. And so I think that that's just because what is in the literature might not be what we're using in our day-to-day practice. So as such, I do want to just say that this isn't the final blueprint for harm reduction. Yeah, it's just a summary of the literature so far. So let's get started and look at some of these attributes. So this is, the first one is quite unanimous in the literature, and that's that harm reduction focuses on the harms. It focuses on reducing the harms of drug use rather than on preventing, eliminating, or reducing that drug use. So that would follow then that any abstinence approach, an approach that is aimed to make people abstain from drugs or alcohol, cannot be considered harm reduction because those are aiming for reduction of use rather than reduction of harm. So on an individual scale, a focus on harm could mean supporting a client to change their mode of administration of their drug of choice. So perhaps from injecting to smoking their drug, where the risks are a little bit lower. On a larger scale, a focus on harms could be evidence-based drug education for youth, rather than some of the not so evidence-based drug education that youth are getting, which is where this image here is from. It's the This Is Your Brain on Drugs campaign from a while back. I'm sure, well, you're probably old enough to know. But this was an example of something that it's not focusing on harms here. This is an abstinence approach. This is not giving you any actual information about drugs or how to use them or what they can do. It's just trying to promote complete abstinence from them. So not a harm reduction approach. The next one is the participation of people who use drugs. So harm reduction values people who use drugs. They're key stakeholders, or they should be, in all aspects of program planning and delivery. This means there's a high value on peer approaches and street-based outreach. And believe it or not, this is actually an emerging attribute. It wasn't found earlier in the literature at all. It's a more recent thing, but that might be why the participation of people who use drugs is kind of missing from some harm reduction initiatives still today. So an example of this is VANDU, the Vancouver Area Network of Drug Users, established in 1998. And these were drug users who came together to represent and advocate for their concerns. I think that an important consideration here is the historically tenuous relationship between people who use drugs and institutions. One of the authors I reviewed urged that drug users need to be at the very center of harm reduction, and they should be the driving force rather than governments or well-meaning nonprofits. And I think that idea is really important to keep in mind. And then the statement, "nothing about us without us," I'm sure you've all heard it, originates in the HIV movement, but definitely has been co-opted as well by the harm reduction movement. The next one is harm reduction promotes human rights. Harm reduction supports the right to health, self-determination, self-preservation, and to be treated with dignity and respect. And although these things weren't always discussed as being human rights related, the ideas of dignity, respect, compassion are mentioned a lot in the literature. So although it's kind of inconsistently addressed, I felt like it was still definitely a key attribute. So the idea of being treated, that drug users should be treated like a human being with rights rather than as a criminal, even though in some contexts the use of drugs is considered criminal still. So these humanistic values of dignity and respect are aligned with human rights. And so harm reduction promotes the rights of humans. The next one will not surprise any of you, I'm sure, and is very consistent in the literature, is that harm reduction is a public health approach, right? It's closely tied to public health principles and population health promotion. And this is primarily because of its roots in the HIV movement. The literature also suggests that harm reduction should be considered part of a comprehensive continuum of care for people who use drugs. So that includes prevention, education, treatment, and follow-up. So it's not a standalone solution to drug-related harms. As we know, in Canada anyway, the public health angle of harm reduction has been pretty consistently used to garner support for harm reduction initiatives. I feel like I hear about that a lot. It's sort of the primary approach that people push when they're trying to promote harm reduction. Okay, the next one is a little bit more contentious. It's debated in the literature. It was a challenge to try and bring it together in words. So harm reduction can be considered value neutral and it's about value neutrality and non-judgment. And that's related to, drug policy, how we feel about drug behaviors, what are our values related to drug policy and people who use drugs. So this is the most contentious of the attributes identified, and it's one that I think is changing the most rapidly as well. Some harm reduction advocates will avoid all the moral questions about, drug use and what the role of the government should be in preventing or interfering with drug use. And so historically, harm reduction has maintained a mostly neutral stance towards drug policy and the criminalization of drug use and the people who use them. And this may have been in part to avoid political tension at the time,
Did Cynthia call to hero?
Okay. If someone doesn't have their mics muted, that would be delightful if you could mute them. So several authors had discussed that this is actually a strength and a limitation of harm reduction.
What? Yeah.
Hey, can everyone just check that their mics are muted? Just take like a quick second to check.
Yeah, and if not, Dominique, you can also mute everybody if ever it gets to that point. Yeah, I mean, then after that, they have to unmute themselves to speak. But sometimes I do that just because I don't have a lot of patience for repeating these when there's like a talk. So I usually will just mute everybody if it gets to that point. Sorry about that.
No, that's okay. I'll just keep going and then we'll figure it out if it gets to be an issue. Okay, so where I was just saying that yeah, this is both a strength and a limitation of harm reduction, because those broader systemic goals of like what are we trying to do in terms of drug policy, how do we feel about these things, those broad systemic goals haven't been defined. But now, as we're seeing, we have calls for decriminalization, we have calls for safe drug supply. So it's clear that harm reduction values are being defined now, and supporters of harm reduction are no longer neutral on these topics, and they're actually engaging with the political tension as a result. So even saying that, though, value neutrality, however, still does continue to be widely presented as a fundamental part of harm reduction, along with non-judgment and non-judgment of people who use drugs and their behaviors. And this is evidenced by the common phrase, meeting them where they're at, which initially meant leaving your own values and morals about drug use aside so that you could provide non-judgmental care. But I think this phrase is now being used more to emphasize, compassion and client-centered care. Oops. All right, next one here is that harm reduction is practical and pragmatic, and this is very consistent in the literature. So it's practical in that it's a realistic response to an immediate need, and it's pragmatic in that it's a sensible thing without concerning itself with any particular ideology. And this actually might mean that sometimes it means doing things that are not entirely legal or that are unsanctioned. So again, going back to that anarchistic vibe in which harm reduction has its roots. So an example is the overdose prevention sites that have popped up as a practical response to the immediate need for these services. This image here is from the Moss Park OPS in Toronto in 2017. Another example is when Vandu in Vancouver, they established an unsanctioned needle distribution service in Vancouver in 2001. And that was a practical, pragmatic, and quite effective response to the HIV crisis that was occurring amongst injection drug users in the downtown east side. They knew that it would help, and despite it not being legal, and despite getting into some trouble, they did it anyway because they knew that that's what needed to be done. And here's the last one here, which is also consistent in the literature, is that harm reduction is adaptive and innovative. It's, you got to be flexible, creative, and always evolving our responses to meet the dynamic needs of people who use drugs. So that means, innovating to minimize the requirements for involvement in a service and to increase access in whatever way possible. So, for example, in some of the places I've worked, we were noticing that it's a barrier to track people by name. They don't want to give their name when they're accessing harm reduction resources. So, we had to find other ways of tracking people so that we could report to funders, but so that we could break down that barrier and they would still want to access the service. Another great example of harm reduction innovation is mobile supervised consumption. These images here are from the one that was developed in Calgary, but there's many others in the country and around the world. And so in Calgary, people who use drugs are not centralized, they're not all located in a single area. And so this was an approach that could help bring the service to where it's needed most, while having the flexibility to adjust the hours and adjust the locations as needed. And I say could because unfortunately the service isn't currently operational due to the change in priorities as a result of our not so new government in Alberta here. So the whole program is under review, and will remain to be seen if funding will continue, and we should know about that really soon. So this quote at the bottom here, harm reduction is a living document, I thought was a really nice way that one of the authors talked about this concept, where harm reduction is constantly changing and accommodating community needs. And as such, it will look different. It will vary by context, location, and community. So this is a strength, obviously. But in this way, it also might be difficult for policy to keep up with some of these emerging practices because they're new. And that also makes it difficult for funders to accept the changes and the deviations from what's established harm reduction practice or harm reduction responses. So again, here we have a key attribute of harm reduction that is both a strength, but also presents some significant challenges because there's no single way to enact harm reduction. And it has, you know, intrinsically a very dynamic approach to it or aspect to it. So those are the 7 attributes. And now that we have reviewed those, let's put them into practice. Let's look at a case study. So in this case study, all 7 attributes are present. This is not to say that like all attributes of harm reduction will be present at every instance of harm reduction, but there should definitely be a few. As we consider this model case, consider the attributes that we've discussed and where they might come into play. Some of them are present more than once, and some of them are quite subtle. So let's listen.
Jeff is a 28-year-old construction worker with a recent history of injecting opioids. He has been intermittently homeless for several months since he lost his job and apartment following a hospital stay. Jeff has been accessing a busy, government-sanctioned, supervised consumption service that recently opened following an unprecedented increase in opioid-related overdose deaths in his city. When he enters the building, he is greeted warmly by name by the peer worker, who then asks him how his day is going and directs him to a vacant booth. As Jeff settles in and prepares his injection using the sterile equipment provided, a nurse approaches with a wheelchair, and since he often falls asleep after injecting, kindly offers it to him so he can be moved aside for monitoring, so the booth becomes available to the next client. Jeff is feeling irritable as he is not injected in many hours and begrudgingly obliges. The nurse is not bothered by this, and noticing that he is quite shaky, offers to help Jeff prepare his equipment for self-injection. Jeff declines and mutters, "I should have done this hours ago when my buddy offered his needle." The nurse gives him a gentle smile and says, "I'm glad you came here instead," and packs him a small bag of sterile injection supplies that she offers to him just in case. Jeff injects his dose and promptly dozes off. The nurse moves him to another location, watching him closely for signs of overdose. 20 minutes later, Jeff awakens and prepares to leave. The nurse asks if she can take a quick look at his veins for infection. And as she does this, Jeff asks how long it takes to get started on opioid replacement therapy and if people are successful with it. The nurse answers his questions, and the peer worker offers to connect him to a local group of people with a history of drug use called Grateful or Dead that meet monthly to share stories, provide outreach, pick up discarded needles, and advocate for policy changes. Jeff says he will consider this, and as he is leaving, the nurse invites him to return.
I hope that helps illustrate some of these attributes. And I know that many of you have lots of great examples of harm reduction in your work as well. And I'd love to hear about how some of these attributes are present or are not present. So moving forward with the next phase of analysis was looking at the consequences. So consequences are, what has occurred as a result of the existence of harm reduction and what might be possible because of the existence of harm reduction. So on the left-hand side here, we have historical consequences. I think you're probably familiar with a lot of these, but harm reduction has reduced the impact of HIV, AIDS, and hepatitis C, reduced mortality and morbidity for drug users, increases capacity for communities and individuals, and increased uptake of treatment services for people who use drugs. On the right, these are the emerging ideas that are increasingly possible, I believe, partially as a result of the existence of harm reduction. So first, I think it's pretty clear that harm reduction is helping to reduce the stigma around drug use and people who use them. We're talking about it, we're working to ensure that people who use drugs are not dying, and that is step one of reducing stigma. Still a lot of work to do though, of course. These next two concepts, benefit enhancement and benefit maximization, are very new ideas, and they refer to the idea that all individuals who use drugs are using them for a reason and are getting some sort of benefit out of it. So thus, it's possible to imagine that there's ways of enhancing or maximizing these benefits while decreasing risk or perhaps even eliminating risk associated with use of that drug. These emerging concepts extend those principles of harm reduction towards recognizing the possibility for non-problematic substance use. These ideas allow for a view of substance use as potentially beneficial or even therapeutic when used in an informed way and while using safer practices. So not only does this contribute to destigmatizing all drug use, but particularly recreational drug use, it might also over time serve to normalize research into the use of illegal drugs, such as psychedelic drugs, for prescribed therapeutic purposes. So examples of these would be the use of MDMA in ecstasy to enable healing for people with post-traumatic stress disorder. Or another example is the use of psilocybin, which is a compound in magic mushrooms, to treat chronic depression. And so this might seem a little bit far out, I know, but the fact that harm reduction has gotten us to where we are now is making some of these things possible. It's allowing for that leap of consciousness, if you will. I think that was a pun. I don't know. All right, the next one. We're going to look at some related concepts. So these are things that were in the literature, but you know, they were not explicitly or exclusively related to harm reduction. So just things to think about. So first off, harm reduction doesn't appear to have a specific approach to drug policy that it's promoting. However, the use of prohibition laws and criminal law incarceration of people who use drugs, that is not harm reduction. That's very clear. But legalization, decriminalization, there's kind of no defined approach currently. I think that might change very soon. That is attached to harm reduction. The next one, approaches to reducing drug-related harm in youth. There's really not a lot of literature about the use of harm reduction practices with youth who are using drugs. And I think that's because when we're talking about youth, it's kind of a whole nother can of worms. People are really uncomfortable thinking that youth are using drugs and etc. So suffice to say that there isn't much to go on when it comes to youth and harm reduction, but it's certainly an area that needs to be explored more. This next point is only going to be meaningful for you if you already have an understanding of this primary, secondary, tertiary prevention language, in which case you're a public health nerd. Welcome to the club. So here's an image to hopefully make it clear. And I'm going to give you a little example that's not drug or harm reduction related. So if we wanted to reduce the harms of exposure to the sun's harmful rays, primary prevention would be to stay in the shade, wear hats, and if you have to go out in the sun, you know, wear long sleeves. Secondary prevention would be to wear sunscreen, you know, limit your time in the sun and make sure you get screened for any signs of skin cancer. Tertiary prevention would be to promptly treat any skin malignancies, any cancer, so that they don't metastasize and create even more harm in the body. So in the literature, going back to harm reduction, it wasn't conclusive as to whether harm reduction is primary or secondary prevention, and I've even found some sources that refer to it as exclusively tertiary prevention. And I think that this is because harm reduction can actually fit into any and all of these categories all at once, depending on the perceived risk level associated with that behavior. So for example, harm reduction education in high school classrooms, for example, I did this in my old job, that would be primary prevention because it's going to affect many, many people whose risks at that time are generally considered to be low. An example of secondary prevention would be providing drug checking services to youth or, you know, maybe at a festival to people who are using recreational drugs. Or even honestly providing injection drug use supplies to drug users, because here the perceived risk of harm is higher. And then lastly, tertiary prevention is, providing naloxone and overdose teaching to someone who's at high risk of dying of an opioid overdose. So here the risk level is the harm that could be done is very high. And so you're probably asking, like, where does supervised consumption service fit in? And I would say all of the above, because there's a lot of things that happen in the supervised consumption service. So yet again, here we have harm reduction is super hard to fit into these neat little boxes that academics like, politicians like, and healthcare providers like, right? I feel like if harm reduction had a relationship status on Facebook, it would be, it's complicated, but super interesting. Okay, how are we doing for time here? We're okay. So what is in harm reduction's future? Where is it going? There's some really interesting discussion happening around the politicalization of harm reduction, where it's being tied to a certain ideology. So I want to consider a few quotes here. First one is by the executive director of the Harm Reduction Coalition. When we talk about harm reduction, we often reduce it to a public health framework, one of reducing risks. That's harm reduction with a small HR. But harm reduction with a capital HR is the movement, one that shifts resources and power to the people who are most vulnerable to structural violence. Here's another one. This one is from the amazing Garth Mullins, who, if you haven't checked out their Crackdown podcast yet, you need to. It's incredible. Any approach to the overdose crisis that doesn't seek to smash white supremacy ain't worth shit. So in these statements, there's a clear trend towards the infusion of political ideology and of changing the status quo, and that's within harm reduction, and I kind of am just throwing these questions out there, but what are the benefits of infusing harm reduction with political ideology? What kind of positives can we achieve with that? And then on the flip side, what are the drawbacks of doing that? What might be some, unintended consequences that we should consider? What does it mean for the future? It's just something to think about. I do want to, if I have time, give you a quick cautionary tale, if you'll humor me for a second here. And it's related to just this whole politicalization and what does it actually mean? So back in the 1960s and 70s, psychedelic-assisted therapies were being researched and discussed as treatments for a whole variety of illnesses. This research was publicly funded. Governments were proud of the work of psychedelic researchers at that time. We had actually a lot of it happening in Saskatchewan. However, when Timothy Leary came along and his counterculture crew, they started espousing the benefits of psychedelic drug use outside the clinical context. And this contributed to, a moral panic about drug use and what it meant, and that, it's going to overturn the status quo. It became very political, and it scared the crap out of people. And I think that might have been inevitable just because of its time and, the context of it. But unfortunately, it did contribute to the war on drugs, where prohibition and social pressures caused the support for psychedelic research to flounder and then eventually stop altogether. And it's only now, some 50 years later, that we're seeing a reemergence of this really promising research, but it's not without trepidation. There's still some really strong associations with psychedelics and certain controversial ideologies. So looking back, we're able to clearly see the damage that was done to this industry, to this field, as a result of associating psychedelics with strong and controversial and hippie political ideologies. Though I don't think that it was preventable. So going back to harm reduction, I wonder, it isn't impossible that the politicalization of harm reduction might actually reduce government and public support for harm reduction. And that might affect funding for these important initiatives as well. If all people who support harm reduction, all harm reductionists, if we're all perceived to be super far left in our political ideas, might that reduce support for harm reduction in those who don't identify as being in the far left? Is there a place for people to support harm reduction that might not support, say, drug decriminalization or safe supply? So it's something to think about. What is the harm reduction agenda We certainly have an agenda. What issues are foreseeable that we might mitigate through thoughtful and intentional discourse about it, so that we don't alienate some of our supporters? Now I'm going to step off my soapbox. And a couple more things here before we open it up to discussion. Harm reduction has come a long, long way since its official debut. And I think it is going to continue to evolve so long as the harms of drug use are proliferating. And the harms of drug use aren't going away anytime soon, unfortunately, because prohibition is alive and well as a drug policy. So that being said, I hope that it helps to have a greater understanding of harm reduction so that we can prevent it from becoming just a buzzword that people throw around without really knowing what it means, or from becoming something that's so poorly understood that it loses support. I'd love to hear your thoughts on what the future of harm reduction should or shouldn't look like, as well as like what you've observed in your practice and in your work environments. You know, what was prevalent in your practice in terms of the attributes of harm reduction, and which ones were missing, and why do you think that is? So thanks again, everyone. And